This is the first grand rounds on promoting evidence-based practice and reducing low-value care. I want to talk about evidence-based practice and sort of the elements of what is evidence-based practice. And then I'm going to highlight what our committee 2 target guidelines are. And then the next grand rounds will focus on how did we come to those target guidelines, and how did, for example, Choosing Wisely, how were those sent to Choosing Wisely? I want to indicate that material on evidence-based practice is in fact sourced from Professor Carl Hennigan, University of Oxford, who's the director of evidence-based practice at that university in England. So what is the definition of evidence-based practice? Evidence-based medicine is really the integration of the best research evidence with clinical expertise and with patient values. It combines, it takes what is the research, evaluates the research, and attempts to then apply it to clinical practice. And our purpose in focusing on evidence-based medicine and in this grand rounds is to develop strategies to assess the quality of evidence for health claims, effectiveness, and applicability. And we want to look at the quality of evidence. What is the size of the effect of the intervention or lack thereof? And then who exactly does it apply to? Some of you may remember these images. These images relate back quite a number of years ago, back into the late 1950s and early 1960s. Francis Kelsey, at that time, was a new FDA employee. This had to do with the drug thalidomide, which was being widely promoted in Europe for pregnant women for an antiemetic, excuse me, nausea, and also to help them sleep. As we are, I think, painfully aware today, there is a lot of politics in terms of healthcare. And in this circumstance, Merrill was pretty big pharmaceutical company, had sent out, I think it's somewhere around 20,000 samples, describing it or had distributed samples to more than 1,000 US doctors to distribute to 20,000 patients as part of what they were calling an investigational trial. Francis Kelsey, against all odds, really, rose to say that the FDA should not approve Kevadon or thalidomide, and that saved many childhood and birth deformities. And that is simply paying attention to what the evidence is. Question, would any of you have agreed to participate in a placebo-controlled trial of prophylactic antibiotics for colorectal surgery after 1975? And this shows, let's see if I can, this shows a number of different studies that looked at antibiotic prophylaxis for colorectal surgery back in 1975 in the 70s and 80s. And there is very clear evidence that prophylactic antibiotics for colorectal surgery makes a difference in terms of patient outcomes. Again, I can remember back when I was first practicing. I'm not a surgeon, but prophylactic antibiotics were not being used when I first began my practice. Next question, would any of you have put babies to sleep on their tummies? And there's a difference between consensus-based practice and evidence-based practice. And The expert opinion of baby and child care and Dr. Spock was that babies should be placed on their, should be placed prone on their front, because there was a concern that if they were placed on their back, they would perhaps regurgitate and choke. The evidence, however, said otherwise. And what they found was greater than a 4 times increased risk of sudden infant death syndrome with infants being placed face down versus on their back or on their side. Again, there are multiple aspects of this study, but you can see that really most of the effects, almost all of the effects, favor the non-back or or favor the fact that other than the prone position is optimal for infants. This actually is SIDS rate and sleep position, and you can see that as it became known and as evidence was followed in terms of practice, that the SIDS rate per 1,000 live births went down, really went down by 2/3. And that, of course, is what we try to do in terms of public health, is follow evidence and lead to improved outcomes. Why we do randomized controlled trials. This was a book written on deadly medicine. In the early 1980s, there were some antiarrhythmics that were introduced, which were found to be highly successful at suppressing arrhythmias, but not until a randomized controlled trial was performed was it realized that although these drugs suppressed arrhythmias, they actually increased mortality. And it was quite a bit of mortality, excess mortality of 56 per 1,000. That's significant excess mortality. And there was concern that by the time these trial results were published, that there were at least 100,000 patients who had been taking these drugs. Avandia, or rosiglitazone, was a drug that is still available, although it's still available in the US, although it is not available in Europe, in Spain, and in many countries in the European Union. It is a drug that reduces insulin resistance. However, it has been found to increase congestive heart failure, increase the risk of cardiovascular disease and stroke. And I can remember when initially it was a very popular drug. Its initial, in its first year, its sales were over $2.6 billion. That fell quite dramatically after the publication of some randomized controlled trials. And then just, there are some drugs that take a long time to come to market and they get approved for use. This is a timeline of historical events in the development of aspirin. And you can see that dating back to the early 1900s, when aspirin was actually first stamped as a medication. 1974 was the first randomized controlled trial of aspirin and MI. In 1980, the FDA approved aspirin after a stroke. And in 1985, it approved aspirin after an MI, or even in use in 1996 for use in a suspected MI. And there were some excellent randomized controlled trials that looked at the proportional effects on MI, stroke, and vascular death. 11 randomized trials of prolonged antiplatelet therapy versus control, and found that antiplatelet therapy was better. And while I don't have the significance here, in virtually all of the studies, it showed that antiplatelet therapy was better. Then, of course, the question was, well, is aspirin can we use aspirin prophylactically? Because the other studies were in patients who had had an MI. And the answer was that in primary prevention without previous disease, aspirin is of uncertain value, as a reduction in occlusive events need to be weighed against any increase in major bleeds, and there are further trials that are currently in progress. My understanding is that aspirin is recommended in patients who have had an MI, who have had a stroke. It's not currently recommended as it was many years ago. If you were over 50, you were supposed to take an aspirin every day. Then I thought that I would mention hydroxychloroquine, because this goes to show about the value of studies and the fact that we really need to assess studies. There were some expert consensus in favor of hydroxychloroquine. There was expert consensus against the use of hydroxychloroquine. There was a study that came out in Lancet, which showed increased risk of death and cardiac dysrhythmia. That study was retracted because it was found that the authors never had access to the raw data. There have been a couple of other studies that have since come out from that, one of which showed that that led to the revocation of the emergency use authorization of hydroxychloroquine to treat COVID-19 patients. There's another study that's come out, and then there was a study that came out that showed there was a question of is hydroxychloroquine helpful as post-exposure prophylaxis? And the current answer to that is no. There are a lot of studies going on, and originally one of the things that our committee had talked about was perhaps looking at doing a evidence-based medicine, low-value care grand rounds on hydroxychloroquine. Only problem with that is there are so many studies that are coming out on a daily basis that it would be very difficult to keep up. One week we'd have a presentation, and the next week it potentially could be completely different. So there is an evidence pyramid, and the evidence pyramid helps us analyze articles and data and conclusions that come out in terms of practice. At the bottom of the evidence pyramid is editorials and expert opinion. And as you go up, you get case series and case reports, case control studies, cohorted studies, randomized controlled trials, and then at the top of the pyramid are systematic reviews. That is, reviews of the literature on a particular topic, on a particular question, attempting to find the answer to that question. This was British Medical Journal in 2008, said a 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. So the 5 steps of evidence-based practice are, number 1, formulate an answerable question. So with regard to our target guidelines, the answerable questions would be, with regard to sinusitis, number 1, are antibiotics helpful in terms of the treatment and shortening the course and reducing complications of acute viral sinusitis? And in terms of low back pain, the question, and again, I will go into this more in the next grand rounds that we do, the question is, does imaging in low back pain assist in the diagnosis and treatment and clinical outcomes of patients with low back pain. In any question, you formulate your question, you track down the best evidence. You critically appraise the evidence for validity, for clinical relevance, and for applicability, because there are a significant number of studies that will come out that give a conclusion, and the conclusion doesn't quite fit with the evidence that they're presenting. I can remember a number of years ago, patient experience has been a particular interest of mine, and there was a study that came out that said that higher patient satisfaction was associated with increased cost and increased mortality in patients. I found that a little bit hard to believe, and so I looked at the study, actually wrote for our emergency medicine newsletter. So I looked at the study and found that they had assessed patient satisfaction in the year 0. They had assessed cost in the years 1 through 5, and they had assessed mortality in the years following that, so that they did not study patient experience in the same years that they studied cost or morbidity and mortality. And so I came to the conclusion that that their conclusions were not warranted, and that they had basically done data mining and had come to a conclusion that they wanted to come to. So sometimes you do have to critically appraise the evidence, and then apply the conclusions that you feel are relevant, and look at the particular issue that you're focusing on, and determine whether the evidence is applicable to your patient population, or in fact to a particular patient, and then eventually come back and evaluate your performance, which we are in the process of doing. Now, one last thing to focus on before I focus on quickly on the target guidelines. Why do we look at evidence-based practice and attempt to accept the conclusions that others have come up with regard to, hang on, I have to, there we go. I have to admit somebody. Why do we do that? And the answer is that we don't have time to keep up with all of the articles that are coming out, and this is especially true these days with regard to dealing with the COVID pandemic. Let's see how I can. If you look at the National Library of Medicine, and Diagnosis Pro has 11,000 diseases, 30,000 abnormalities, 3,200 drugs, and the FDA has over 18,000 products. And as William Osler said, to cover the vast field of medicine in 4 years is an impossible task in terms of training. In terms of the epidemic of evidence that needs to come out, we can't do this without skills to critically appraise the material on which we are basing our practice. In fact, if you look at the number of articles that come out on an annual basis, the rise has been exponential. In addition to that, you and I we have to help our medical staff critically appraise articles that come out, because there is often poor randomization. If you get reviewers, in terms of reviewers, all peer-reviewed, all papers that are published in many of the major journals are peer-reviewed. That is, for example, I review probably around 15 potential articles for the American Journal of Emergency Medicine every year. And the truth is that reviewers don't do very well. We don't often detect all the major errors, detect that there's poor randomization or a poor response rate, which can affect outcomes. So there was a study, the British Medical Journal study of 607 reviewers, that confirmed that there are significant limitations to peer review. Let me focus now on what our target guidelines are, and then I'll bring this to a close. So we have two target guidelines. One is avoid the prescribing of antibiotics in the emergency department for uncomplicated sinusitis, and the other is avoiding imaging in uncomplicated low back pain in emergency department patients. Choosing Wisely was created as an initiative of the American Board of Internal Medicine. I think we're all familiar with that. There are more than 80 specialty societies which have identified commonly used tests, treatments, or procedures. And one such category is prescribing antibiotics for patients with viral sinusitis. Acute rhinosinusitis, the definition is there. The most common etiology is a viral infection. Treatment focuses on symptomatic management. Typically, symptoms resolve in 7 to 10 days. Bacterial infection occurs in only at max 2% of acute rhinosinusitis, and even that can be self-limited disease. Treatment is symptomatic. There are no treatments really to shorten the course, the clinical course of the disease, and I'll present some of that data in the next grand rounds. Acute viral rhinosinusitis may not completely resolve within 10 days, but it's expected to improve. And those who fail to improve after greater than 10 days may well have a bacterial secondary infection. Here are the indications for urgent early referral of patients with sinusitis. The key thing here is that when we diagnose bacterial rhinosinusitis, bacterial etiology needs to be defined. So if a patient has sinusitis and the clinician indicates that the patient has bacterial sinusitis, then that patient is excluded from our numbers. Our current data is that 55.49% of patients are given high quality care. That is, they did not receive an antibiotic prescription for uncomplicated sinusitis. That's based on last year's data. I have not analyzed first or second quarter of this year, but that's the data on which we based our target. There was wide variability among our members of the Louisiana Quality Network in terms of care received, with a percentage of high performance ranging from 12.8 to 88.9%. And as I mentioned, if bacterial, it may be excluded, but there has to be a diagnosis code for bacterial infection. Treatment, I mentioned previously, it's really symptomatic, and there are some resources. Diagnosis and treatment of low back pain in the ED. Our measure description, and there has been some confusion with regard to this as to whether we're looking at those who did or did not receive an imaging. In this circumstance, the numerator statement is patients who received an imaging study. The denominator is all patients with the principal diagnosis of low back pain with the exclusions that are noted there. Interestingly enough, the NCQA estimates that Around 30% of patients presenting to an emergency department with a complaint of nonspecific low back pain received an imaging study. I believe that was in 2017, 2018. For all facilities for Louisiana Quality Network, 61.8% of Medicaid patients did not receive an imaging study. Now I'm going to go back. This was 29.9, around 30% did receive an imaging study. So therefore, we have to look at where we are, and we're at 38.2% did receive an imaging study, so we could do better. Wide variation among member hospitals, this in terms of those who did not receive an imaging study. We have some that have exceeded the benchmark of the NCQA, and others that are doing significantly more poorly. Our target guideline is to improve high performance by 20% during the year 2020. I've included in this, and I sent this out, I'll send this out again. There is a specific algorithm that can be used with regard to patients who present with low back pain. These are available and could be potentially posted in your department. And the key points are that imaging is not generally needed to diagnose acute low back pain. It can lead to expensive, unnecessary interventions. And if you take people at the age of 50 and you do an MRI on them, 50% of those will have a distinct abnormal finding, but there's no way to specifically identify that what you're seeing, the abnormality that you're seeing on your imaging, is causing the patient's pain or the patient's disability. Red flags need to be identified through a patient history. 90% of patients will respond to conservative treatment, and you can see there what first line treatments are. One of the things that we often don't recommend is physical therapy, and that's something that I think we could vastly improve on in terms of recommendations when patients are discharged, as well as exercise. There are a number of references. At this point, I would say that with regard to evidence-based medicine, recognize what your questions are, select which questions you need to pursue, ask for guidance in terms of how to ask so that you can get appropriate answers, and then we need to assess how well we're doing and what we need to improve. How long do you need to try to do evidence-based practice? And the answer is far too long for most of us. So it's a matter of getting started and just having a deliberate practice. And with that, I'm going to close this portion.